Collaborate, connect.
Health Administration Research. Submit your article to Jackie and be a part of us.
JAGI is a scientific journal for health administration research. The scope of JAGI includes healthcare management, healthcare leadership, healthcare organization, healthcare policy. Bring your ideas to the world. Let's collaborate with the research. JAGI serves criteria and connect to researchers around the world through our journal. Click the link to know about JAGI. Don't forget to follow JAGI Facebook and Twitter at JAGI Office.
Indonesian Journal of Health Administration. Be a part of us.
Selamat sore, good afternoon, Bu Ratna, Prof. Adam.
Good afternoon, Pak Trias. Thank you.
Mohon maaf Bu Dekan nggak bisa ragu karena ke bawahnya.
Ya, Pak Trias, matur nuwun sudah kerso mewakili untuk memberikan sambutan nanti.
Terima kasih Pak Trias. Mungkin saya bisa sapa dulu ada
Iya.
good morning, good afternoon Prof Adam. Are you there?
Good
Hi.
morning.
Good morning. Now
Hello, good morning, Prof. Adam.
Hello.
Greeting from Indonesia.
Greetings from England. Thank you very much. It's great to be with you.
Thank you, thank you.
Prof Adam, maybe I can introduce you to Pak Trias. Pak Trias is our Vice Dean in Faculty of Public Health. And we also have Bu Ratna. Bu Ratna is our Head of Department in Health Policy at Administration Office. And we also have some people here. Maybe I want to introduce you to our team from Jaki, Aisyah and Mas Arif.
Hello, nice to meet you all.
Hello, nice to meet you too, Prof.
Hello. Those backgrounds are fantastic. I really like them.
Thank you.
I think we also have some people from our alumni from short course that we already have in Coventry in 2018. I see that Pak Angga, maybe, wait a minute. Pak Angga, are you there?
Yes,
You can say hello.
Hello, Agus. How are you
hello,
doing?
Prof. Adam Layland.
Nice to see you.
Hello, Prof.
It's been a long
Nice to see you
time.
too.
Yeah, that's great. Yeah, when we
You are in the car. Hello.
banyak ya. Wait, maybe. Okay. Yeah. Okay, Prof. Adam, maybe we also have our master student that that will be one of person that will share the experience in Indonesia. There is Bu Rofida. Yeah, and also Pak Fatur ya.
Fantastic.
Yeah.
Fatul.
Pak Fatul. Yeah, and we also have Bu Diar as the moderator today. Okay. I think it's already at 3 o'clock. Maybe we can start now.
Oh, where is Pak Ilham?
He will join us after this because he has a problem with the electricity at his home.
Oh.
Yeah. Can we start now?
Yes,
Okay.
of course.
Yeah.
Okay, we start ya Pak Trias ya.
Iya, monggo Bu Ratna, Bu Ulul.
Okay. So Aisyah will be the master of ceremony. Go ahead, Aisyah.
Okay, thank you so much, Bro. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, good afternoon and also good morning to the first one, the Vice Dean of Faculty of Public Health, Universitas Airlangga, Mr. Trias Mahmudiono, SKM, MPH, PhD. Second one, the Head of Health Policy and Administration Department, Mrs. Ratna Dwi Mulandari, SKM, MKes. And the third one, our Editor-in-Chief of Jaki, Mrs. Nuzula Kusuma Putri, SKM, MKes, and also our Honorable Speaker, Prof. Adam Layland, and also all of our colleagues. My name is Aisyah Rafi, and on behalf of Health Administration and Policy Department in Jaki, we are pleased to welcome all of you to this guest lecture titled Best Leadership Practices from NHS During COVID-19 Pandemic. In this guest lecture, we will be discussing about some cases related to healthcare leadership in Indonesia, which will be delivered by Mrs. Rofida Latifah, Dr. MKes, and also Mr. Fatul Munir Darosa, SKOP MKes. We will also have a great session of lecture with Prof. Adam Layland from NHS. And now we will be moving on to our next agenda. I would like to request the Dean of Faculty of Public Health Universitas Airlangga, or the Vice Dean of Faculty of Public Health Universitas Airlangga, because our Dean cannot be here together with us in this afternoon. So I would like to request Mr. Trias Mahmudiono to deliver his opening speech in this afternoon. Mr. Trias, time is yours.
Okay. Thank you very much, Mbak Aisyah. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon for all of us, and also good morning for Prof. Adam Layland. Thank you very much on behalf of the Faculty of Public Health, especially the Department of Health Administration and Policy. We would like to send the gratitude from our Dean, Dr. Santi Martini. Is actually very excited to have you as one of our long collaborators related to staff exchange. We know that Ibu Nuzulul and Pak Ilham have come to England, to UK a few years back, and from the Faculty of Public Health, we are really happy that we maintain this such a good academic atmosphere and a sharing session, and also guest lecture from Prof. Adam Layland. Thank you very much, Prof, once again. And for all the students, we also appreciate that this opportunity by Prof. Adam Layland is rare, and please be active and engage in the conversation and lecture, so we can learn a lot from each other, because in the developed country like UK with the NHS, they have certain type of leadership, and in Indonesia we also have experience. If I'm not mistaken, some of our alumni will going to sharing the leadership experience related to COVID-19. Thank you, Dr. Rofida Latifah, MKes, MSc, Bapak Fatur Munir Darosa, SKOP MKes, and also I would like to thank the moderator as well as the MC for today. We hope that in this difficult time of pandemic COVID-19, we can still maintain our health through many means, including health protocols, vaccinations, nutrition, exercise, and etc. Which, in my opinion, it needs a good leadership, because without leadership, as we know, in some cases in Indonesia, we have kind of like one time ago, between the central government and the local government, they have different what do you call a type of approach, which sometimes it create confusion among the people, and us as a public health warriors, we need to be in the front, especially in terms of health promotion and education related to the mitigation of COVID-19, as well as the prevention effort that we need to do. Once again, enjoy the guest lecture by Prof. Adam Layland. Thank you very much, Prof. I know that you also one of the member, what do you call, from Jaki editors. Thank you very much, and also appreciate for Jaki to support this event along with the Department of Health Administration and Policy. Congratulations, Ibu Ratna. We hope this activity will induce student curiosity and insight related to the leadership, which are part of our what do you call outcome for health administration and policy program. Once again, thank you very much for your time and opportunity, Prof. And we hope in the future, when the situation is under control and traveling is can be done, in person or offline. When few years ago, couple of our lecturer come to UK, and we hope next time you can also come to visit Indonesia. We're gonna take you to Bali, Bromo, and have exercise and as well as learning each other. Thank you very much. I think on behalf of the faculty, we going to declare the guest lecture open. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Mr. Trias, for your the first speech. And now please allow me to invite Mrs. Nuzula Kusuma Putri as our editor-in-chief of Jaki to deliver her speech, as well as she maybe introduce some of our colleagues here. Mrs. Nuzula Kusuma Putri, time and screen are yours.
Okay, thank you so much for coming. Actually, I want to say first of all, thank you so much for Adam for accepting our invitation to our guest lecture, and we really honored to have you here. And I also want to introduce you to our faculty. Actually, our Faculty of Public Health, we have master program in health administration, so that's why we want also to share their experience, that most of them are also health practitioner in Indonesia, and that's why also Jurnal Administrasi Kesehatan Indonesia JAKI as journal in our department is very enlightful that our alumni also can share the experience. Let me check I think we have, like I already introduced before, we have Bu Ratna. Bu Ratna, can you say a word for Prof. Adam, maybe?
Hello, morning, Adam.
Morning.
Okay, thank you for your cooperation today.
Yeah. No, thank you very much. Thank you for the invitation.
Okay, and we also have Pak Jazuli. He is the head of our study program for a master degree. Pak Jazuli, can you say a word? He's not here. Okay, maybe it's not here. Okay, I also want to introduce Adam to everyone here, that Adam is one of our editor in Jurnal Administrasi Kesehatan Indonesia, and he's very supportive for us. We already collaborate since 2008 in 2018 when we have a short course in Coventry University, and we still continue to cooperate until now. Then we really appreciate that Adam can share the experience about leadership in NHS. So maybe that's a word for me. And we also have a student from bachelor degree, Adam, actually here. They are public health student, and they have a class about leadership and system thinking in healthcare, and they're really eager to know the application of healthcare leadership. And we also have some alumni and health practitioners that also join this lecture. Thank you so much, Adam, for coming.
Thank you ever so much for inviting me. And can I just start by extending my sincerest appreciation to the Universitas Airlangga, Jaki, the Faculty of Public Health Administration and Policy, and thank you to the Prof. Trias, the Vice Dean, for his lovely invitation and opening speech as well.
It's ours, yes.
It is wonderful to be with you all today. It's early in the morning in England. The sun is shining, although I would much prefer to be with you in Indonesia. And in 2019, so the year after colleagues visited England for a short course sponsored by the Ministry of Research and Education, I had the absolute pleasure to come to Indonesia, and I visited Jakarta and Purwokerto I spent a week overall. So it would be lovely to come again and to see you in person at the next opportunity. I'm also really keen to learn from you as well. So whilst the NHS is often seen as, you know, a great healthcare organisation in the world, I'm also very aware that Indonesia has been introducing universal health coverage. And that's the program in 2018 that Nzulu and colleagues on the call attended as well. Ilham and Anger are the two people that I can pick out straight away. And what that really highlighted to me is the opportunities we have to learn from one another. Yeah. There are so many great things that we can do together, but there are also even better things we can do when we learn from one another as well. So it is my absolute pleasure to be with you as esteemed colleagues, practitioners, alumni, and students today to discuss leadership. I thought I'd just start by giving you a little bit of an outline of my role and what I do. So I am the National Head of Commissioning for Health Education England. And what that means is I support the NHS across England to ensure that we have the right number of students training to become healthcare professionals. And that's any type of student, that's doctors, nurses, allied health professions, public health practitioners, clinical psychologists, mental health practitioners, any profession that we have in England that we fund and train through the NHS. I'm connected with and with colleagues, of course, as well. In England, for our health education training, we have what's recognised as the largest budget in the world for training staff to join the NHS. I should have done the calculation to work out how many Indonesian rupees this is. So that's a task for somebody to do whilst I'm talking. But the British pound sterling that we spend every year on educating the future staff and current staff of the NHS is £5 billion worth of funding. So yeah, I'd love to know how many Indonesian rupees that is, because that will be a lot. Please do get involved as I'm talking today as well. So ask any questions or type into the chat and I'll try and pick it up. So as well as my role in the NHS as the head of commissioning across England, I'm also the chair for the UK for Healthcare Organisation Management with the British Standards Institute. And what we do there is to develop standards across England to support healthcare organisations to deliver better welfare for the staff, better care overall. There's a standard we're working on at the moment, which is about artificial intelligence in healthcare, which is obviously really prominent throughout COVID and as an emerging technology. So I've got some fantastic colleagues leading on developing a standard of ethics for artificial intelligence in healthcare. In addition to that, I'm also on the International Standards Organisation Committee for Healthcare Organisation Management. And I've been leading a fantastic team of people who are developing a healthcare quality management system standard. So this is looking at our ability across the world to deliver excellent and outstanding healthcare quality to staff and to patients as well. And this is looking about how organisations work together, not just individual organisations. It's very much about a system approach, and I'll explain a little bit more about that in a minute. In addition to that, I'm also a trustee for a charity in England. And so there's a few examples I'm going to talk through in a bit about how the charitable sector and the leadership in charities as well has been helpful throughout COVID and where we've got to. I'm a governor for one of the largest NHS organisations, which is the University Hospitals of Birmingham. And I've been a governor there for 3 years now. So that's given me a lot of insight into the way that a large organisation is run in the NHS. I'm a consultant paramedic in primary care. So I support the delivery of services in primary care, and I was across there yesterday to see some staff. I'm a professor at York St John University for leadership and management in healthcare, supporting the MBA program at the university. And finally, I am a very proud member of the editorial board for Jackie as well. It's been great to get involved with Jackie over the years. And I'm sure all the 186 people on the call would have read my article in last year's Jackie, I think, or the year before. So if you haven't, then please do. I think I did the editorial for one of the first publications of hard copy of Jackie. So very, very proud to be involved and supporting the team in Jackie as well. So what I thought will be a good place to start is a little bit of an outline of the structure of the NHS. So we often consider the NHS as one organisation. It's one way of working, and that's what it is. But the reality is the NHS is a brand. It's an umbrella term for all of our healthcare funded by the government in England. And so the way that this works is through the Department for Health and Social Care. It is obviously where the government gives all the money to for healthcare. And that's then distributed to an organisation called NHS England. And NHS England is the primary organisation in England to look after the NHS. So they get probably about £140 billion a year to support and run the NHS. That's then devolved into what's currently known as clinical commissioning groups. So clinical commissioning groups are then there to commission and provide the services through different organisations to patients. So it kind of keeps filtering. It starts off very high at the government, NHS England, clinical commissioning groups, and then to what we would call a provider organisation, a hospital, or what we call in NHS terms, an NHS trust. And they deliver the services to patients. So if you think about that from a leadership perspective, multiple layers of leadership, and within each of those layers, there are multiple layers of leadership. So we start to build what's called a matrix way of working. So there are multiple leaders in multiple organisations trying to run the NHS. And what we have with that then is about 500 different organisations. So 500 different leaders, 500 different top teams, etc. And in primary care for general practice, there's about 8,000 general practice surgeries across England as well. So if you consider this from a leadership perspective about how the message from the top, so right from the top of the NHS, filters its way down to everybody so that we've all got clarity, is really difficult. And we're a very small country in comparison to Indonesia. We've only got 70 million people. I think the last count was about 270 million people in Indonesia. We've got very, very difficult ways of communicating with our populations and the people that make up the countries. But that problem's the same. It's just the volume is obviously very, very different. So having 500 different organisations, 8,000 primary care organisations, which are their own organisations as well, makes leadership across the NHS extremely difficult. So hopefully what I'm going to talk to you about today is some aspects that I think are really important for leadership across that type of matrix environment, across so many organisations which make up our National Health Service, but also to think about where leadership is best effective. So we've got 3 levels in effect through the structure of the NHS. We've got what we call place, and that's the local area. That's your neighbourhoods. That's the on the ground connectivity amongst a population. We then have a system, and a system is made up of multiple places to become a healthcare system, and roughly our systems are capturing between 1 and 2 million people in a system. And then we have our regions, which are multiple systems together, which form a regional area. And then we have the national aspect across the country. So 7 regions make up the national aspect. So instantly, I'm sure many of you are thinking, that's complex, that's difficult, that's a lot of different leadership areas, a lot of different contrasting views from place to system to region to national. And the key aspect is always about the interrelationships between these areas, these constructs that we put in. And leaders have probably not worked out exactly the best way to do this yet, because priorities and complexities change. So I'm fortunate to be both in a system and in the national. So I can see the paradigms between both of these ways of working. You know, in my national role, I'll want to do something once across the country, get it right. And in my system role, when people do that, I'll go, well, that doesn't work for me. How do I make that work for me? Because I need something which is going to help my system, not what the national is telling me to do. So it becomes extremely complex and extremely difficult in balancing that overall. But I've got some examples in a bit to tell you where it's worked extremely well during COVID as well. So we have to think about this whole approach between what's the local and the place thing to do versus a centralized and national way of doing it. And there are benefits and disbenefits to both. Benefits of centralizing and bringing together a national way of working is that you get consistency, you get efficiency, and you get effectiveness. So everybody gets the same, therefore you get equality and equity and access overall. However, what that may not do is address those very local population needs at that time. So we've been able to manage both of these throughout, and I'll talk to everybody about that in a little while and give a little bit more detail as well. So hopefully that's a little bit of an overview of the NHS, and it's extremely complex, and I usually give a talk on the construct of the NHS for about an hour and a half anyway, so I'm not gonna go through that now. But just to get across the point as I go through the leadership bits is it's a complex organisation. It's multiple organisations which make the NHS, and leadership is across very different levels throughout, in very senior ways as well. So there's going to be 3 key points that I want to talk to today, and I've purposely not done any slides so you can see me and you can hear me rather than looking at slides and things. So point number 1, that I'm going to talk through. Point number one for my tips around leadership and what we've learned is to focus on the right thing to do. Point number two is about listening, learning, and acting. And point number three is about communication. I'm going to take each one of these in turn, share some thoughts and share some examples with you. Does that sound okay to everybody? Yeah, great. I can see some nods of the head. Fantastic. Thank you. So let's start off with focus on the right thing to do. So often a leadership trait, when you compare, this is often a leadership trait when compared to managers who do things right. So leaders do the right thing, managers do things right. So what that's suggesting from a managerial point of view is it's more of a process, it's a tick box. It's I have to do it this way. I've been told that's the right way to do it. Whereas leaders do the right thing. Might not fit in that construct, that process, that way of working. But leaders will always do the right thing overall. And there's been a long view across the British public that NHS management is a waste of money, that it's too top heavy, that all they do is walk around with clipboards, auditing, looking at things, not actually doing anything. That's been the perception of NHS managers. And whilst that might have been true in the past, the NHS has been focusing on leadership rather than management for well over the past 10 years overall. So it's absolutely vital that we understand what leadership is. And what makes this challenging is there's over 4,000 definitions of leadership, which really makes it very difficult for people to say, oh, okay, what is leadership overall? So I'm going to share with you my favorite way of thinking about leadership. And it's from a US president from years ago. It's not Donald Trump, don't worry. It's from a very long time ago. It was President Eisenhower, who said, leadership is getting people to do something you want them to do because they want to do it. So I'll say that again. Leadership is getting people to do something you want them to do because they want to do it. So what this says to me is it's hugely important for leaders to be able to influence people and get them on board with things because they take ownership, they really want to do it, but you've got them doing it as a leader. And so what this does, particularly, and why I really like this as a leadership definition, is it brings people together, it gets people on board with a vision, going forward with where they want to go to, because they really want to do it, not because they've been told to do it. And there's a huge difference there, isn't there? When you think about if you're told to do something, that's very managerial. And yes, at times we have to be told to do things and we might not like it. But if you get people wanting to do something you want done as the leader, how much more powerful can that be? How much more impact can that have? Because when people take on that responsibility, they're going to do a brilliant job with it. And that's my biggest focus on leadership, is getting people to do something I want them to do because they really want to do it. And I think this sets a fundamental aspect of doing the right thing across an organization, across a system, and across a country. Because leaders set the tone, leaders set the pace, and leaders set the standards of an organization or a way of working. And so that helps people to meet a set vision and a set aim overall. However, without setting those expectations, it's really easy for anybody to justify their work to an aim or to a vision. So that's where leadership needs to be strong, needs to be clear, and it needs to be consistent. I'm sure we can all think of different examples where, you know, somebody's done something because they felt it was the right thing to do, and they can justify it against a vision, they can justify it against an aim, but actually the tone wasn't right, the pace wasn't right, or the standards associated with were not right as well. So we've got to make sure that's lined up for people to be able to do the right thing overall. And we've seen this throughout the pandemic, where overnight, and literally overnight, how many people became an expert in infection prevention and control? How many times have we seen people doing something around preventative measures to stop the spread of COVID, which from a public health point of view and a proper expert's point of view is completely the wrong thing to do? And we have seen that so many times throughout the pandemic in different sectors, in healthcare, in leisure, in hospitality, in transport. And I've been flabbergasted at times to see what's been happening and how people are making decisions, which again is a fundamental leadership aspect of doing the right thing. Now, I absolutely get that everybody set out to do the right thing. I think that is what's driven it. However, when we go into the next bit around listening, learning, and acting, that's how we check we're doing the right thing. What may seem logical and right to one of us may not seem logical or right to somebody else. And that's where you need to make sure you've got your networks, your connections, and your real experts to talk to. And being public health experts on the call, I'm sure you've seen many different examples, which has made you kind of scratch your head and go, I really don't know why they're doing that, because that's not going to make any difference whatsoever. But sometimes it makes people feel better because of it. A really good example of this, not from the NHS specifically, but from the hospitality sector, is so when compulsory face masks were introduced for everybody, the certain parts of the hospitality sector got these visors. I don't know if you've seen these big visors which kind of come down like that. There's nothing really covering your face, but it's coming down like that. So you're, when you talk and when the air flows out your mouth, it won't go forward. So that sounds great, doesn't it? You know, it's one way of restricting the flow of any transmissible disease. However, consider it from this point of view. If you're being served a meal and you've got a face mask like this, the visor over your head, so it's got a gap between you and there, and you're talking and you're breathing, where is that airflow going? It's going straight down, isn't it? Straight down, you're breathing out, it's hitting the visor and it's flowing straight down. And if somebody is serving you a meal, what are they holding in their hands directly below that? That's where your food is. And so instantly trying to do the right thing by, you know, I can't wear this because it's going to restrict me and people need to see my face and, you know, I'm a waiter. But you're instantly flowing all of that air downwards onto people's food. So that's, for me, somebody set out to do the right thing, but they didn't understand the consequences. They didn't understand the impact that would have because they didn't engage with the experts and seek to understand what that may do. Now, I absolutely appreciate potentially at the time of this happening, nobody really knew how COVID was being passed and transmitted to everybody. And that transmission we now know a lot more of, both from a droplet secretion point of view, but also, you know, the aspect of it staying alive as an airborne virus for a specific period of time as well. So whilst we can understand the right thing to do at times, or we may be able to go, well, that seemed right to me, then you've got to engage with people. You've got to set out to understand what's going on. And, you know, another good example is around one-way systems. So I'm sure you've had this as well, where, you know, we don't want people being too close to one another, so we introduce one-way systems. And I've seen one-way systems that go in and out the same way. How's that going to work? How's that going to help when your one-way system might only be internal, but there's only one door still? And what's the process around that? How's that working? And I've also seen, and it does depend on the design of buildings and what have you, but I've also seen one-way systems which are probably only about a meter gap to be a one-way system, and a long stretch with that. So we've got to think outside the box at times, but we've also got to be practical in doing the right thing overall. So how does one know? Sorry, I'll start again. So how does one know what the right thing to do is? And this is where it becomes tricky. So I'd say a lot of this comes with experience. Not only your own experience, but having a network of people you can call on confidentially when required to ask a question to help build your experience. And if you think about what makes somebody an expert, like a sports person, it's practice, isn't it? It's repetition. It's making mistakes and it's doing it again. You know, if you are a runner, the best way to become a better runner is to run and keep running. If you're a swimmer, the best way to become a better swimmer is to practice swimming and keep swimming. And this is what experience is about, for you to understand what the right thing to do is. You've got to keep practicing it. Got to build that network, have those conversations, have that confidential chat with people to help build your experience as well. And leadership needs exactly the same as what sports people do. You need practice. You need a coach. You need space for people to grow. And it needs failure to become better. So I used to teach, when I used to teach at the university, I used to teach that fail was an acronym. It's not a word to me, it's an acronym. And FAIL stands for First Attempt in Learning. We are all going to make mistakes. We're all going to fail at something. You know, I do it on a daily and a weekly basis, but it's what makes us better. It makes us better leaders. It makes us better humans as well. And we need that space to learn. We need to give leaders the opportunity to develop and learn and make mistakes, as long as the mistakes are not going to impact. And that's why you need your network. You need to check things out before we do make decisions overall. And this links with something called the unconscious competence model. So what this model suggests is that when we start out, we don't really know what's happening. We don't know what to do. As time goes on, we might recognize what's happening, but still we don't know what to do. As that develops even further, we know what to do, we know what's happening, but we need to think about it. So we're consciously competent with that. And then as time goes on, where expertise comes in, you become unconsciously competent. You don't need to think about it because you're doing it and you do it all the time. And that's the development of leadership for me, is getting us to that stage where you can do it. You don't need to think about it because you've done it in the past. You've got the experience to be able to do it. It's a bit like riding a motorcycle. So as a young child, as a baby even, and a toddler, you don't know what a motorcycle is, you don't know how to ride one. As you grow up a little bit, you start to know that a motorcycle gets you places. It gets me around, but I still don't know how to ride one. So at that stage, that's the turning point, because you know what this motorcycle is for and you can learn how to ride it. So you become consciously competent when you're learning how to ride it. If you think about riding a motorcycle, you're thinking about moving and what have you. You'll be thinking about, I need to look, I need to check, I need to do this before I ride my motorcycle. Although now, when you've done that for a long time and what have you, how many people get on a motorcycle now and you just get on and off you go, you do it. You don't need to think about it because you're doing it. That's exactly the same with leadership. You can apply that to driving a car as well, and everything like that. And that's where leadership is as well. It's getting us to that unconscious competence state. So it becomes second nature in what we do. So our concentration then can be focused on what we believe is right. And that's based upon experience, on failure, and successes in the past as well. However, it doesn't mean what you do is always right, because we can get bias. We can get tunnel vision, focused on one thing to do, that we miss many others around us. Or even more dangerously, we could do something without considering the consequences of it. And we've seen that throughout COVID, in decisions being made which may appear to be the right thing to do, but with a little patience and a little thought, the problems lying ahead probably would have been seen, so we can combat that first. However, in a time of crisis, it is human nature to react, not to delay things, to do the most for the most, but sometimes taking a slightly slower pace, to be considered, to be compassionate, and to allow that thinking time means your decisions will be better, you will have greater impact from those decisions, and your decisions will be sustainable. Although, on the contrary, sometimes we know consequences of a decision. Sometimes we do know the consequences of making a decision, but we still have to make that decision anyway, knowing full well that in a week or in a month, we've got to change because we can see that consequence coming. And this comes down to, again, that practice, that expertise of doing the right thing now. But again, I might need to change that in a couple of weeks or a couple of months because I can see this is going to be a problem. But right now, that's the right thing to do. So doing the right thing should not be subjective. It should be clear. It should be unambiguous. And it should be directed towards the outcomes anticipated overall for staff and for patients in a healthcare environment. So here's some examples of this for us to bring this a little bit to life. So when the pandemic struck last year, and March and April last year, we started to see the transmission of the virus hitting thousands of people a day, many people getting hospitalized, and sadly many people have lost their lives, as we all know, around the world. So we need to make quick decisions as leaders of what we're going to do. So at that point, across the NHS, there was a decision taken to cancel or postpone hospital appointments. So this decision was to make sure that the resources, i.e. the staff, were moved to where the greatest need was at that time. So there are some pros and cons to this. The pros are that we can absolutely divert staff who are expertly trained to the area of greatest need, whether that's intensive care, the emergency department, screening services, triage services, etc. What that does, though, is it can create an uncomfortable culture for staff. They may not have worked in intensive care for a very long time or done it ever before. We opened up major new hospital sites across England in arenas. These were rapidly, and when I say rapidly, these were very rapidly developed across the country, what we called our Nightingale hospitals. And we had, I think at the peak, we had 5 of them able to be operational, but only 1 or 2 ever actually became operational overall. And this created additional capacity to support the growing numbers of patients that required the healthcare services and access to healthcare. It happened in a matter of weeks. So we went from a blank arena to building thousands and thousands of beds in these arenas within a matter of weeks. And that was the right thing to do. Absolutely. Because with that moment in time, we didn't know how many people we'd need to be treating. We could see what was happening in Europe, particularly. We could see the aspects of how many people were overwhelming the health service. And we knew as a country, we couldn't be in that situation. We absolutely had to protect people as quickly as we can. And that's where the Nightingale hospitals came from. However, because of that, you can't open a Nightingale hospital in an arena with 1,000 beds without any staff to do it. So we had to make a decision as a country to divert staff from their normal work to support the Nightingale hospitals, to support the peak and the number of patients that the NHS was starting to see. And these were specifically COVID patients as well. But what that does is it starts a whole process, doesn't it, around thinking around training. How do we train people in these areas? How do we support them? What's the governance? What's the risk associated with that? And what we thankfully saw was we didn't need to use the majority of the Nightingale hospitals because we could cope, because we had the right decisions being made, because we had the focus on treating and doing the most for those patients presenting with COVID at the time. And if you think back to, well over a year ago now, we didn't really know what COVID was doing or how transmissible it was. And we started out with, if you've got a cough or a high temperature, get yourself checked because you might have COVID. How many people have coughs all the time? How many people can get a high temperature all the time? A little infection, an ear infection, a throat infection. It happens, doesn't it? But one thing we got right, I think, is that recognition. If you've got a cough, you've got a high temperature, you need to think that you might have COVID. And then as time developed, we recognized that you lose your sense of taste or smell. So we were building on the evidence, we were building on what was happening at the time. And this is where, as a leader, making the right decision in hindsight can change. But we can only make the right decision on what we're faced with at the time. What's in front of us at the time? What are the experts saying? What is our network saying? What are our people saying overall? So cancelling or postponing appointments and moving the resources to a different area at that moment in time was the right thing to do. However, what have we got now? We've got a waiting list of 5 million people that need to access services. And because of that, all of the NHS staff have worked terribly hard over COVID. And there is a mass exhaustion. Everybody's really tired. We've thrown everything in. Everybody's worked so hard to deliver new models of care, new ways of working to support patients, as has every healthcare member of staff across the world. But now we're in a situation where we've got an exhausted workforce and a growing list of people who need healthcare services because they've put it off because of COVID. They don't want to go out and catch COVID. And if you're accessing healthcare services, you are ill. There is something that makes you more susceptible to getting a virus, perhaps. You also consider that growing list now of people who have had conditions maybe for a year or two, their conditions are getting worse because they've not been treated, they've not been diagnosed, they've not accessed the right prescriptions or the right services to help them get better. So we're going to see a longer term approach of more complex patients, longer term care needs, because we cancelled and postponed so many appointments in the outset, which again, at that moment in time, I absolutely agree was the right thing to do. But this comes back to being a leader and thinking about those consequences, thinking about the way ahead, thinking about, okay, I've got to make this decision now, but what's the earliest opportunity I get to change this decision to make sure I'm still doing the right thing overall? The British Medical Association estimated that between April 2020 and March 2021, there was 3.37 million fewer elective procedures in hospitals and 21.4 million fewer outpatient attendances. So all of that adds up to a much longer term problem around how many people now need to access health services. And we've got to be thinking now as leaders across the world in health services, what's the right thing to do so that people can get treated, diagnosed, and recover from all the illnesses and injuries and exacerbations that they've had over the last 12 to 18 months, so that we have a healthier population going forward. Because we know a healthier population will help to reduce the possibility of a virus killing people and making people more unwell overall. So the other thing that we had happen was around primary care. So in primary care, and doctors, general practitioners, they generally stopped seeing people face to face. It all went online. And we know there's healthcare practitioners on the call as well. There are only so many things you can do online when you're trying to assess a patient. Sometimes you absolutely need to be hands-on. And I'm really proud that my service in the Coventry and Warwickshire area of England, we expanded, and I made the decision with colleagues to expand our paramedic service in primary care to go and see patients in their own home on behalf of doctors. And that was a decision we took very quickly because it was the right thing to do. We could not have people not being treated and not being assessed and treated because they couldn't get a doctor's appointment, because they couldn't go and visit a surgery, etc. So we put measures in place so that our staff, our paramedics, could go out and see people overall. And what that does, it helps to limit the spread, it helps to contain it, because we can put the measures in compared to the public going around and going into doctor's surgeries, etc. So again, it comes back to thinking through the right thing to do and what's that long-term approach with it. And we are still seeing all patients in their homes through our paramedic service in primary care, and that will continue forever now, because it's absolutely the right thing to do for patients, the right thing to do for society overall as well. So how do you assess whether the decisions we make were the right thing to do or not? So we've got to consider what we knew at the time and what we know now. By doing the right thing doesn't mean we don't go back to it. We absolutely need to go and check back on what we've done, what decision we've made, to make sure it is still the right thing overall. And vaccinations are a critical aspect of this. So the UK government invested very heavily initially in different vaccinations, and of course, through both the AstraZeneca Oxford vaccine and through the Pfizer BioNTech vaccine, we were able to really rapidly support the vaccination program. And I think as we are today, it's about 30 million people in England and the United Kingdom have been vaccinated against the coronavirus, which is over half the population now, and a much higher population of adults specifically. So at this moment, if you are aged 23 or over in England, you can now access the virus, access the vaccine to help you with the virus. Everyone can access the virus, can't they? But we don't want them accessing the virus, but you can access the vaccine if you're 23 and over at this moment. And this comes back again to that centralisation and national approach that I talked about earlier, where you can have that approach which has sorted out vaccines across the country immediately. And that's the right thing to do. You've got the centralised way of working, and we've got major centres which are vaccinating people across the country. But we've also got that place-based approach. What's the right thing to do for a local community so everybody accesses the vaccine to save them from the virus as effectively as possible? So it's vital that we don't just do things in a time of crisis because it's the easiest thing to do and disguise the outcome into the crisis. We've got to focus on what's the right thing to do, build that network, build that understanding. I'm going to go through the second 2 points as well. These sections are a bit quicker, so don't worry. But I thought the right thing to do is absolutely the fundamental aspect of being a leader. So the second point was about listening, learning, and acting. And it balances out doing the right thing as well. So we must listen to others, those that are delivering services, those that are receiving services, about what matters to them. If it's a leader's responsibility to support the front line in healthcare, we need to know what's happening, not what may have been happening when that leader was doing the frontline role years and years and years ago. Because things move on with team dynamics, team culture, practice, and despite the fundamentals of care being the same, as leaders, we've got to recognize this and remove that bias or remove that optimistic perception from the reality of what's happening overall. So we do that by listening. But how do we actually listen to learn? Do you actually listen to answer? Or do you listen to think? Or do you listen but don't hear? So during times of crisis, what we can do is get in our own little bubble or our own world. And we hear what we want to hear to justify our way of thinking or our actions. So we aren't truly listening. So how do you know when somebody is truly listening? And the key test for me on this is them being able to repeat back to you at the time or at a later date what you've said, or more importantly, at that time, for them to ask you a question. And that way you can tell they've been listening to hear, they're inquisitive, they're open-minded, and they're seeking to learn. So when listening, it's vital you're not just listening to ask a question, though. You need to listen to absorb, to contemplate, to critique, and then formulate your questions on what you've heard. And I adopt, and my tips and what I've seen throughout the pandemic is adopting a critical thinking approach. So considering the who, what, where, when, why, and how. So who benefits from this? Who is it harmful to? What is another perspective? What is most or least important? Where will this idea take us? Where are the areas for improvement? When would this cause a problem? When will we know if we've succeeded? Why is this the best or worst case scenario? Why is there a need to do this today? How do things dispute this? And how can we change this for good, or for our good as well? So approaching critically helps you, helps others, and helps leaders to understand the ask. What's that vision, the aim overall, like I mentioned about doing the right thing? Because by understanding the ask, understanding the vision, understanding the aim, it helps feed that back into doing the right thing. So when we've done all the listening and learning, it can't just stop there. The key aspect of being a leader is to be able to do the right thing. So from listening and learning, we have to then act. It doesn't need to be immediate action, but what we can learn can help our thought process as leaders, help our planning, and ultimately then help our patients and our staff as well. And action can be taken in numerous forms. It could be a very small change that needs, which has a huge impact. Tiny changes can have major impact. Or it may be something bigger which needs looking at, which needs a programmatic approach overall. So an example of this that I've seen throughout the pandemic is in the way that we support our staff and support our patients overall. And what can happen is we can get quite siloed in the way that we operate and work. And what we do is we can do that from a very singular point of view. And what we've seen throughout the pandemic is we might go and do something for nursing, but we completely forget all the other professions around it. And it creates more difficulty in then trying to reconciliate all of that overall. So we've noticed, and what we've learned is to be multidisciplinary in our approach, in the way that we offer services, offer support, and offer funding to do new things. We've also noticed it in the deployment of our students, specifically to support healthcare services. We have been in a situation where we've had to deploy final year students to support the health service to deliver care to patients. But through listening, through learning, we've then been able to act in a better way for the future aspect of deployment. And we're not always going to please everybody, but we have to do what's right overall and how we support people overall to do the right thing through thinking about the way we undertake our work, following listening, following learning overall. The other thing so one thing I've been working on throughout the pandemic is introducing a new NHS education contract across England. And this was to help us to get to a strongest place to deliver education and training across the country. And through that, we've been able to listen, we've been able to learn through dialogue, through conversation, through webinars, through consultation exercises, so that we're able to get this right in the long run. Because this contract lasts for 3 years. So we need to do that listening and learning to be able to get it right first time overall and do the right thing with that. And that links to the third point about communication. Leaders are no good alone. To be a leader, you surely need some followers. So what do your followers want? What do they want to hear? And that we do that through listening, learning, and acting, point 2. But they also want to be engaged with. We need to let them know what's happening, how it affects them, how it makes their job better, and how it will help them to be better overall. And as a leader, we might often have all this knowledge in our heads. We have our vision, we have our way of working in our heads, but it's absolutely no good being there. We need to get it out so that people know and understand it, And that's what having the right and the vital amount of communication should all be about, because we cannot do this in isolation. We have to do it together overall. So how do we communicate? It's about getting the message across in a way which makes sure it's going to be heard. So we need to think about who we're going to be talking to. What do they want? What matters to them overall? If we're doing it on video or in person, body language is so important in delivering the right communication. And when we're not doing it remotely or in person, the tone that comes across, again, is really, really important. We should always check our messages in as well before we do anything, because sometimes looking back at it, thinking about it in a different way helps us. And I don't know about colleagues on the call. I'm not a fan of really long emails or really long things like that. So we need to be brief yet specific. Really long things, people might fade and switch off after a while if it's something that they need to do or listen to. Very different with articles where you're finding out information, but for communications, we need to be brief. We need to be specific. Sometimes it's much better to do it in person or remotely. I class through Zoom or something as in person now, because you can see the people. It's not on a telephone, it's not on a conference call, it's something slightly different. And of course, think before you speak. A lot of leaders get caught out with this by not actually thinking before they speak. So there are a number of tactical measures that we have now everywhere in the world, and using Zoom and Teams and what have you has become second nature to a lot of people. But we have face-to-face, we've got email, we've got social media, seeing people in person. It's always vital as a leader to let people see and hear it from you. Don't just rely on it going out through chains and different leaders. Really importantly, see it and hear it. And now we can do videos much easier. Everyone's much better with technology. They can be sent very quickly, and it's better than a depersonalized email. So emails are very good at getting messages across, but they depersonalize it. It's not about you, because how do you know you're saying it? How do you know you're writing it as such? But also with communication, we need to think about communication upwards. So how do senior leaders know what's actually happening? What's that mechanism for feedback? And it's absolutely vital in absolute what I've learned throughout the pandemic. Feedback is the most important thing from loads of different people overall. So the main test of how your message is communicated is when you hear other people saying it. If you know your message has got out there, people are using it, they're saying it, to me, that's a sign of success. That's so important, because you know they've heard it, you know they're using it, you know they've interpreted it. But think about when we get communication wrong, or when we don't communicate. It can lead to serious consequences. It can lead to failures. And ultimately, during a pandemic, it can lead to death. We've got to be really clear in the way we communicate and who we communicate with. I think it's always vital that we map out everybody that needs to be communicated with, so we don't leave people out overall. So some really quick examples on this are around regular briefings. How do we inform people? How do we have check-ins? We go back to that centralization versus local. Where does the message need to come from overall? What does wider engagement look like? How do we have different aspects of that engagement to deliver the same and the right message that people want and people need to hear overall? And again, it links back to listening, learning, and acting. So I'm going to sum up now, and I'm happy to take any questions. Appreciate the time's moving on as well. So some things to think about. So as leaders, we have numerous responsibilities. We have responsibilities to our organizations, to our teams, to our patients, to our staff, and to ourselves. We can't forget that within this. Some key takeaways. So remember, leaders set the tone, the pace, and the standards. That gives boundaries of which everyone in an organization can work to. To be a great leader, you need to know how to listen and question effectively. So you listen to learn, to understand, and you ask to make it better and to drive to the right thing. And you can never have too much communication. Find out what works for your audience, your staff, your patients. Think how you would want to hear what's going on, but also recognize your position in that. You're going to know it, but if you weren't the person knowing it and doing it, what would you want to hear overall? Our NHS Chief Executive, Sir Simon Stevens, has always said, think like a patient, act like a taxpayer. So as a leader, you've got to think about what would the public expect of us as leaders. And that should always guide us to do the right thing overall. So my 3 tips for great leadership that I've considered falling out of the pandemic are: always set out to do the right thing. Know what it is. Have no fear in doing it, but remember there's a fine line between fearlessness and arrogance. So watch out for that. Listen, learn, and act. So you actively seek out to do this. Don't hide behind your usual network and develop your questioning skills. And finally, communicate, communicate, communicate. Adopt multiple ways of communicating, and you will know when it's working when you hear people repeat it back to you overall. I would like to thank you again for inviting me to speak with you today. I hope that's been of usefulness and helpfulness overall. It's been my absolute pleasure to do this. I'm very happy to take any questions. And again, thank you to Jackie, Universitas Erlangga, and the Vice Dean as well for offering your warmest of welcomes and your offer for me to speak with so many great colleagues today. I hope you keep safe and well, and thank you very much for having me.
Okay, thank you, Professor Adam. I would like to introduce myself first. My name is Diar. I'm one of the alumni from Magister of Health Administration, and actually I'm acting as the moderator for today's discussion. So sorry for the late introduction. Before we enter the discussion session, we would like to hear some sharing session for our alumni. And I would like to present Mr. Fatul Munir Darosa. He is one of the alumni from Magister of Health Policy and Administration, graduated in 2017. And now he is working in BD Indonesia as a clinical marketing for East Indonesia and also a co-owner of MKS Clinic in Jember. So Mr. Fatul, the time and screen is yours.
Yep, thank you, Diar. Hi, Prof. Layland, and thank you for the good occasion to share my experience here. Well, I got only 5 minutes, right? Only 5 minutes, okay, no problem. It's a little bit different with Bu Rofida's experience that she will share later on after me. I'm working in the other side of this wide healthcare industry. Just a brief introduction. My name is Fatul, and I'm working in global medical device organizations. I work as a clinical marketing, and I'm responsible for East Indonesia area. I work together with sales team, consists of some sales forces in my respective area. And I can start my experience sharing with a picture for you that clinical education is taking a significant role in our marketing strategy. It is a part of our market approach strategy. Furthermore, we are in the knowledge-driven dynamic industry, and it is important to have a good engagement with our customers along with clinical approach. In this case, in what we used to do in our job, face-to-face meeting with our customers in hospitals is very important part in this process. And our communication with our customers to deliver information about the latest technology we adopt, our support to advance the world of health, the recommendation to utilize our product optimally, product training, clinical trials, clinical research, and so on, and other process and approach to carry out by our Salesforce team in commercial terms to create demand. These activities definitely will be much more effective while we do it in face-to-face form with our customers. So our job is, I can conclude that our job is to getting our customers do what we want them to do because they want to do it. That's leadership, and of course we want them to purchase our products in the end. Okay. However, during February and March of last year, COVID-19 came to Indonesia, visit Indonesia, and it changed everything. You know that I'm working in medical devices company, but these are not directly COVID-19 related products. So do not expect that the pandemic has a positive impact on our business. On the contrary, it takes us into a risk. Along with everyone, including all the hospitals, focus is seized to the pandemic issue, and the BOR, bed occupancy rate of the hospitals generally drop down, and it means a threat to our business. You know, when the hospital BOR drop down means the utilization of our products will follow. It will be less, and it means a threat to our business. All clinical activities and communications I mentioned before, like the clinical seminar, trials, research, publications, whatever, it is not related. If it is not related to pandemic issue, then nobody will hear you. So it changed everything. And the leadership team in our organization has to be agile to respond to this extreme dynamic situation. Right? Then what the leadership team in our organization decides in these situations, we put our associates' safety and health as our top priority. We encourage all associates in our organization, not only encourage, but also we force them to work from home strictly. Violation of this means violation to the company policy. We also provide our associates anything they need to ensure their safety and their health, like proper PPE, work from home equipment, vitamin, and so on. And not only for physical health, their mental health is also becoming our top concerns. Well, we are thinking about business. It means that it looks like we took a step back. We put our associate health and safety as our top priority instead of the business itself. And yes, there are so many new challenges in communication and coordination by adopting the virtual way all the way, because we do everything from our home. But we believe that with fit team, we could always find a way out to solve any challenge. It put our businesses in a not comfortable situation. However, we see that our associates are important assets and capital more than anything else, and more than our business also. And we believe that with good human resources, we could be agile to face any changes and to solve any dynamic challenges brought by this pandemic to our business. And more or less, that is the experience that I could share with you. And of course, I'm expecting comments or advice from Prof. Layland. And I think I got already the 5 minutes. Thank you, and back to you, Diar.
Okay, thank you, Mr. Fatul, for your sharing in business organization about leadership. And next we have Ms. Profida Latifah. She is also the alumni of Health Policy and Administration Magister Program, and also she is also graduated from Magister of Health Management in the University of London in 2020, and now she is working in Mitra Utama Medical Laboratory. So Ms. Rofida, time and screen is yours.
Thank you very much for the time, dear, and thank you, Adam, for attending this event. And hello, Adam. I want to introduce myself. My name is Rofida. I'm a medical doctor. Previously, I worked in a hospital in Jombang. It's a small city in East Java. So I want to share the leadership experience that I knew during this COVID-19 pandemic. Actually, last year I took a master degree in London, so I've experienced myself how the NHS facing the pandemic. I experienced the lockdown. I experiencing the how the GP is closed and I cannot go to the GP if I have an issue with my body. So yeah. However, I came back to Indonesia and things is a bit different here than in the UK. And then this is the leadership experience in the hospital. So in the beginning of the pandemic, all of the staff were confused on how to deal with the disease. I think we are all confused. What kind of virus is this? How to treat the patient? So the staff didn't want to provide the care for a COVID-19 patient. It's kind of different in Indonesia because we are a private hospital, so it's not mandatory for the hospital to treat the COVID-19 patient. It was optional for us. However, the hospital director see that the right thing to do is to provide the care for the COVID-19 patient. So the hospital director had a discussion with the head of medical committee, the nursing committee, and then the infection prevention control team to make the staff and the patient safe, because eventually the hospital need to provide the care for the COVID-19 patient. So after the meeting and after a long discussion, the doctors and the nurse and all the staff were agreed to provide the care for the COVID-19 patient, as long as the hospital can provide the PPE according to the staff risk level. And the hospital can support the staff and the family if they catch the virus. So, and in the end, the director created a team to treat the COVID-19 patient, and one of the hospital ward were turned into the COVID-19 isolation room with the 20 beds. And up until now, the hospital have treated hundreds of patients with COVID-19. It is one of the highest in the Jombang city. So I think it's like what you said previously, because the leader need to do the right thing, and so the hospital director think that the right thing to do is to provide the care for COVID-19 patient, and they learn what is the doctor need, the nurse, what is they want to do, and then eventually the hospital director can communicate with the hospital staff member. So it's not only the hospital director who want to treat the COVID-19 patient, but all of the hospital staff want to help the patient. That's it for me. Thank you very much.
Thank you very much, Ms. Rofida, for your sharing. Before we go on to the discussion session with other participants, maybe Professor Adam, you have any other feedback or comments maybe about the sharing from Rofida and Fatul, maybe?
I just think brilliant examples of doing the right thing, brilliant examples of listening, learning, and acting, and great examples of communication there as well. I think, you know, absolutely brilliant to hear those experiences, brilliant to hear what you've seen as well. And also, I'm very sorry for talking too much and reducing your time overall as well. I'm really, really sorry for that. I lost track of time and get talking, but fascinating to hear what's been going on, and you know, great that, you know, I like the customer, getting the customer to do it because it's what we want them to do, and I think that's absolutely brilliant. And also around the governance and the way of making the right decisions from a private hospital point of view as well, actually recognizing that, you know, we're not just here as a private hospital, we're here to help people, which goes back to that fundamental aspect of leadership in healthcare about doing the right thing for our staff and our patients, regardless of everything else ongoing. So wonderful. Thank you, Fatul, and thank you, Rafida, for that as well.
Okay, thank you, Professor Adam. So, is there any more feedback from Lafida or Fatul, or we can move on to the discussion session? Okay, let's move on to discussion session. I think there's a lot of participants here. It's want to ask some question for Professor Adam or Rafida and Fatul. So if you have any question, you can raise your hand and I'll mention your name and you can open your mic and say the question. Is there any question? Maybe from the students from the bachelor degree or other participants? Hello?
Can I ask a question, Mbak Dia?
Oh yes, please. Yes, Mr. Patrias.
Okay. Thank you very much, Prof. Adam, Bu Rafida, Pak Fatul, dan Mbak Dia. For Prof. Adam, you know, like in Indonesia, we are a huge fan of EPL, English Premier League. You know, the soccer in England, and I'm curious on how the leadership pertaining, you know, the soccer game could be open or not, when, you know, like the club itself want to have it open, to have a you know, like income from the what do you call, the supporters, and the players also want to have a supporters, and you know, in the Euro as well. In terms of leadership, how strong is the bargaining power of the NHS leadership relatively compared to this, you know, football industry, or maybe the government, or any others in the UK or in England? And secondly, as we know, correct me if I'm mistaken, NHS has one of the highest budget allocated to healthcare. Does it make it easier for a person running the NHS in terms of leadership compared to, perhaps, if you know, maybe in some other area, they have like, you know, limited budget. So sometimes people are, you know, like if there's a program, there's a money involved, the leadership are easily, you know, like listened by others. That's one of the case in Indonesia. But what do you think that NHS model can be replicated in a developing country with limited budget like us in Indonesia? Thank you.
Great questions there. Thank you, Prof. Trias. I guess, you know, thinking about football and the soccer analogy that you mentioned, England won the other day in the first Euro match, so that was great news against Croatia. So I guess there's a fundamental difference though between being able to deliver a service to the population versus an entertainment to the population. And now both of them have very strong links to well-being and to quality of life. And there's been some tough decisions that's needed to be made across the entertainment and leisure industry throughout COVID, which does impact on the quality of life, impact on income for people working in those environments and those sectors as well, which ultimately will impact on their health in the short, medium, and potentially long term as well. Not only their physical health, but their mental health as well. I think it's been an extremely challenging time to make the right decision, and fundamentally, the decisions and the leadership has had to come back to what do we need to do to protect the health of the population. And with football and the Euro starting and other events coming about, we've ultimately stuck to our principles as a country to protect the NHS, because we know that if we are unable to deliver care and services to the population through the NHS, more people are going to die, which ultimately results in more health inequalities, more health problems for people, both physical and mental, as I said. And we've had to stick to that principle overall. What's the right thing to do to protect the health of the population and to protect the NHS so that services aren't overrun in their entirety? I guess, when you compare that overall to other sectors and to leadership in other sectors, we have a responsibility in government and in healthcare to protect the people. It's the first fundamental aspect of any government, isn't it? To look after your citizens, look after your people. And the NHS, being part of the government in effect, has got that ultimately in their responsibility. And so what one has to balance in as a leader's perspective is the immediate needs of the population from a virus point of view versus those medium and longer term needs of their healthcare, their well-being, their quality of life overall. And it's such a difficult balance to make, because if you start opening up aspects which will help mental health, will help physical health, sports activity, etc., you do risk the virus becoming more transmissible overall. More contact equals more people becoming unwell. But the caveat with that is around having absolutely clear approach on vaccinations, a really clear policy on how you are going to mitigate and manage that. So that's through wearing the mask, keeping 2 meters apart, washing your hands, and those aspects which are evidentially proven to support a reduction in the transmission of the virus. And so I think in summary, it goes back to the point of doing the right thing, but using that listening, learning, and acting approach so that we're not doing the right thing in isolation. We've got to do the right thing together. And there are many pilots taking place across the country and across the world to understand what is possible and what can we do to support quality of life again, to support people going back to a normal type of life. But it has got to be balanced with how do we continue to protect those most vulnerable in our society, whilst we're also protecting the services themselves. And as I mentioned, we're now seeing more people accessing services in England because they haven't been treated over the last 12 to 18 months overall. And so that is going to compound the issue around opening up society back to what it was like before COVID as well, which is going to again impact on the health service. And we've got to move away from as safely as possible being reactive to what's going on, to being proactive around the health quality and quality of life for the population in its entirety.
Okay, thank you, Professor Adam. Pak Andreas, maybe you have any more feedback or?
Yeah, related to my second question about NHS have such a high budget and in healthcare. How do you think some countries like us in Indonesia can advocate the need for health budget, even though we have universal health coverage with the BPJS, but still the government still not fully funded the universal healthcare relatively compared what NHS did in the UK. What do you thought on that?
I think it's really difficult, isn't it? Because as I learned whilst supporting both the ministry and colleagues with universal healthcare coverage, the ambition, the vision was absolutely the right thing to do. I think what the government in Indonesia have done is set out on the right thing. I think the challenge has been implementation and scalability across the population and across the vast expanse of islands and geography that Indonesia's got. And that's where this aspect that we're still learning about in England around place, system, region, and national is very, very complex. And I guess the funding aspect becomes more difficult because of the cost of healthcare in its entirety, the taxation that causes, the ability across the population to enforce taxation and make sure everybody is contributing in the way that they should contribute towards that, does make it more challenging. When you expand universal health coverage like the Indonesian government has done to areas such as dentistry, optometry, and those areas, your costs are increasing even more because the setup of those services is significantly higher compared to other areas. And particularly in England, dental services are an additional payment for the population. So they're not covered by the NHS. They are subsidised, but not entirely covered. And I guess that may be a possibility around future sustainable funding aspects around universal health coverages. There is always an aspect which is free, which should be emergency care, surgeries, electives, outpatients, ongoing conditions, and what have you. But there should also be aspects which can be funded additionally in a consistent way. So there's not a disparity amongst society, but there is a set tone across the country in its entirety. And I guess with that, it's really important to recognise the expected outputs of universal health coverage and how overall the long term of having universal health coverage will lead to a much stronger society, a stronger economical prospects for the country, because people are living longer, living better, and able to do more overall. And that, for me, is the fundamental aspect of ensuring health is the #1 priority for governments across the world.
Thank you, Prof. Adam.
Okay, thank you, Professor Adam, and thank you, Pak Trias. I saw Bu Inge was raising hand. Are you still here, Bu Inge? Yeah.
Have time?
Yes, please.
We still have time?
Yes, Bu Inge.
Okay. I'm sorry, I think that's not the right time because my toddler needs to bring him to the toilet.
Oh, bless.
Yeah. Maybe if other participants have the other question, maybe I can go next. So I'm sorry, just not.
Don't apologize at all. Go look after him.
Okay,
No problem.
okay, Bu Inge. Okay, any other participant? Do you have any more questions? We still have a few more minutes. Maybe Bu Ulul or the students from the Bachelor program. Yeah, Bu Ulul.
Okay.
Okay.
Maybe it's just like a personal experience for me related to communication things. Like you said before, the communication during pandemic, it must be brief. But sadly, as person like Bu Inge before, that women at home, working at home is always surrounded by their child. But sadly that there are more virtual meeting. There are more. I think that should be, it can be explained in email, but there are more people want to meet virtually and make it more not rationally or working out of our office, and it's quite challenging for women like us with child. So maybe you can share how UK can, maybe like there is any regulation or something guideline for that, to make to ensure that everyone have their personal rights still exist during this pandemic.
I think that's a great question, Zulu, and it's so important around the way that we work now, that we set the boundaries within that. And I think it's imperative on leaders to recognize that and to recognize individual circumstances, because what we've got now is a much better way of having a work-life integration. So years ago, we used to talk about having a work-life balance, and I don't think we need to balance work and life. There should be a separation and there should be an integration overall. And that's what we've been able to do, I think, through COVID, people working at home, working remotely. So I think that there's no regulations and there's no standards that I've seen as such around that. But there are, I think it's incumbent on leaders to recognize that within their individuals of what makes each person productive, what's going to help each person. And particularly what I've seen across my team and across teams in the NHS is we absolutely recognise that. We absolutely recognise people have got children. You've got lives. Children have been off school and having to school from home as well. And I think it's just so important that we give people that flexibility to achieve what they can achieve, and the comfortable ability to recognize it's not a problem. It's absolutely okay. Life is life. There's nothing that we do generally together, which, like Inga's had to take a child to the toilet. Absolutely fine. It happens. And I'm sure there are different mechanisms that we've got that I'm sure she can still hear us. So while she's not on camera, she's still hearing us, still able to be partaking, just in a slightly different way. And that's absolutely fine for me. I think that's the right thing for us to do, to have a better work-life integration overall and be flexible to the needs of people and the needs of family. The door might ring, somebody may knock at the door delivering things. We've got pets and animals which need our attention at times. And that's the way of life, and I think that's what makes us human. And I think when we can have that happening, we actually bring us into the environment, we bring ourselves into the work that we're doing, so it's more personal, it's more reflective of us as individuals, and therefore we can give our best because of that.
Okay, thank you, Professor Adam. I think the discussion getting more various, not only about leadership, but a little bit, like heart-to-heart sharing about the working during pandemic in our office. So is there any more question or maybe discussion for Professor Adam? We still have like 15 minutes.
I'm ready now.
Okay, Bu Inga.
Okay.
Welcome back. Okay,
Okay,
please,
thank
Bu
you so
Inga.
much for the opportunity. So thank you, Prof. Adam. It's very interesting to listen to your lectures, like going back to my PhD and master time when I did to write down all the lecture. So there's some quote that I really love from your lecture. Is about leader have to be strong, clear, and consistent. So if I reflected back to what happened in Indonesia during the pandemic, what we saw from our government is like the contrary. So the leadership of the government is weak, in my perspective, is weak and was not clear and was not consistent. So for example, like this, for example, right now the COVID cases is soaring. but we're still waiting whether the government will put any measure to reduce the spread of the COVID. But like there's nothing, because like in Idul Fitri, like 3 weeks ago, actually government already forbid the community to going back to their hometown to celebrate the Idul Fitri. But the thing is, it's like a joke. So I'm sorry, it's a bit not the right word, but that's the thing. And also, for example, one of my students do some literature review about the policy that implemented by Vietnam and Indonesia during the first 6 months of the pandemic. And from the literature review, we can see that it's like we just like a very slow in making a decision, or maybe when, for example, if the local government say A, but then someone in the, in other level gonna say B, and it's a bit contrary. So for the all community who read the news, who read the social media, we just like get confused, and that's why what happened is we see that there's so many people just like obeying all the health protocol. That's why the cases keep soaring, and that's like it's painful for the health workers, or maybe for the people who try to do the best to avoid the spread of uh, the the virus. So yes, that is a really important quote. And my second question, so that's just like a comment, the first one. So the second question is, because I see that the patient safety in HSS is among the top of the other country, among the best. I forgot to mention that I'm a lecturer in the same department with the Bu Ulul and Pak Ilham. So yeah, and then uh, may I know how the patient safety is managed before and during the pandemic? Because like what you say that the NHS does like a student deployment, and that's bring risk to patient safety. For example, if for example, if the government or the hospital didn't set a clear rules about the deployment, and that will risk the patient. So we're afraid that so many patient safety issue that happen because of the deployment of students, because we think that they haven't graduated yet, and they haven't had the standard skill, whether they have the capability to do the care and something like that. So I think that's all. So thanks a lot for the opportunity, Mbak Diar. Thanks.
Thank you very much. So yeah, patient safety is fundamental to everything that we do, and is, you know, up there with the highest of priorities. I guess I'll just pick up on the deployment of student aspect. So we only deployed students in their final year of their degree within the last 6 months of qualifying. So they got the majority, they've got all of their academic studies done, they got the majority of their practical studies done, and we're in the final section of that practical aspect. So they've got a lot of skills, a lot of competencies. And of course, you know, students are contributing to service delivery overall anyway, just within their scope of practice. And that's the key thing. It comes back to what I said about being strong and clear and with the right boundaries. So being able to set them so people know what they should be doing, what they should be working in, helps them to ensure patient safety, and to ensure that the critical aspect of leadership is considering patient safety as well. We as you know, as you said, it's fundamental part of what we do. It's the number one priority in the way that we run our services, is to ensure that there is safety for patients, and of course to staff in delivering care as well. So it is always balanced, and it goes through listening, learning and acting, and doing the right thing overall. And at that time of deploying the students, it was the right thing to do to get more support to the NHS at the time that it needed it, but within the boundaries that students worked. Thanks for that question. That's a really good one.
Okay, thank you, Professor Adam. Bu Inge, is there any?
One last question.
Okay.
Sorry. If I want to learn about patient safety, do you have any recommendation, or where is the best place to learn about that in UK? Maybe
On patient safety?
Yeah, maybe organization, or maybe institution, or maybe a professor in patient safety or something like that. Thanks.
So Health Education England has funded a patient safety syllabus and a patient safety criteria for education specifically, and that's been worked on jointly with Health Education England and the Academy of Medical Royal Colleges. So the first part of that is available on our website now. So there are some suggestions and guidance documents there. But also on top of that, with the International Standards Organization, we have just released a new standard called patient-centered staffing. So this relates very closely to patient safety to ensure that the right staffing levels are appropriate for the patients that are being treated. So that's just been released through the ISO as well. There's 2 bits off the top of my head. There's probably many more as well.
Okay, how about it, Bu Inge? Is there any more feedback? Enough?
Enough. Thank you so much.
Okay. Thank you very much, Professor Adam and Bu Inge, for the discussion. And is there one more question maybe? I saw there is some students from the Magister program and alumni or bachelor program. Don't you want to say something in this rare opportunity? Are you just going to, stay quiet and listen? Well, even though leadership is also about listening, but yeah, you can also ask him something here.
Listening to learn, and then the act will come later.
Yeah, it's not only listening, right, Professor Adam? No? Okay, if there is no more question, maybe I can summarize about today's discussion. Well, in leadership, there is 3 points or 3 tips that you have to, make it, that you have to remember about the focus on the right thing to do, listening, learning, and acting, and also communication. I think that's the main point from today's discussion, and I hope we don't, not only learn about the theoretical things, but also we can practice it in our daily life or in our working in our work life and stuff, because leadership is not only for learning, but you have to practice it to make it perfect. So I think that's it for me. Thank you very much for Professor Adam for today's session, and also thank you for Prof. Vida and also Fatul for the sharing session, and thank you for the Health Administration and Policy Department for inviting me to today's event. So I'll give it back to the MC, Aisha.
Okay, thank you so much, my dear. Ladies and gentlemen, the discussion and the guest lecture would be our last agenda in today's meeting. May I thank all of you for your active participation in this guest lecture, and I hope you really enjoy the session. But lastly, before we leave this Zoom meeting, we will be having some documentation. So please, for all of the participants, open your camera so we can take some pictures together. Okay. I will count it like until 5, and then we will have some pictures together. 1, 2, 3, 4, 5. Okay, so those who haven't opened their camera, we'll just leave them. Okay. Okay, let's count on 3. 1, 2, 3. Cheese. Yeah, once more. 1, 2, 3. Cheese. Okay, that's all. Thank you so much. I'm Aisha Rafi, and thank you all for your attention.
Thank you very much.
Thank you very much, Prof. Adam.
Thank you.
Thank you, Adam. See you.
See everybody.
Yeah, we can
see you
talk
all soon.
Thank you,
soon,
Prof.
yeah.
Adam. Thank you, Mas Fatul.
Thank you.
Tes,
Bye-bye.
Pak Kakak dan Jaki. Bye.
Yeah.
Thank you very much, Prof. Adam.
Bye, Adam.
Thank you. Bye-bye.
Bye-bye.
Bye. Ya,
Terima kasih banyak
terima
Bapak
kasih
Ibu.
banyak Bu.
Teman-teman, apa ngobrol sama Adam nih, yang teman-teman ex-Coventry?
Udah pada udah
Oh, sudah.
nggak ada.
Ini ada. Hadir.
Oh, Adamnya udah Oh, sudah ini Adam.
Ngobrol
Yaudah,
sama
nanti.
aja.
Nanti kita agendakan. Sorry, nggak bisa ikut full tadi. Oke.
Mas Ilham di mana sekarang?
Aku telat masuknya.
Iya. Oke. Ya, nanti di itu ya. Oke, terima kasih teman-teman. Nanti kita kontak-kontak lagi. Makasih udah mau.
Ya, makasih Mas Mbak Ulul, Mas Ilham.
Ya, oke. Yuk.
Sukses semuanya.
Yes. Saya N ya. Oke.
Ya, terima kasih banyak Bapak Ibu.
Ya.